So hi again, everybody. Today I'm going to be spending some time discussing ways to integrate natural supports into your sessions. So before I get started, I have a couple of quick disclaimers. First and foremost, I want to clarify that the focus of this didactic is not on family therapy. Rather, we're discussing how you can draw upon existing support systems to leverage the work that you're already doing. And secondly, this is a topic that I'm sure is something that each and every one of you is already doing and has experience with. So at the end, please feel free to jump in with ideas on how you're doing this, especially in the era of COVID. I feel like creativity in these times is so important, so the more voices here, the better. So to provide you with a quick overview, I'm going to provide a brief rationale as to why this is an important topic, discuss our main topic, which is integrating supports, touch on some implications for how this might look in the era of COVID, and then hopefully have some time to hear from you regarding questions or ways in which you've navigated this topic. All right, so at this point, there's a large body of literature that supports the importance of this topic, including research indicating that social ties and social supports are positively related to mental health, physical health, and longevity for all of us, but specifically among those with schizophrenia spectrum disorders, we see that higher levels of support have been linked to fewer relapses and episodes of hospitalization, higher rates of medication adherence, and less disengagement from psychosocial treatment. But despite these findings, collaboration between supports and mental health providers is somewhat uncommon. For example, a study examining the frequency of provider contact with families of individuals with severe mental illness reported that the majority of mental health providers reported no contact with families of their patients. And this is likely due to a number of factors, including but not limited to systems issues. For example, very few medical and behavioral health organizations provide training on how to include families in supports and treatment planning. Clinician comfort related to training needs, interest in this work, and limited time and resources. Client comfort, I'm going to come back to this because I'll talk on this specifically in a few slides, as well as issues related to client privacy. And this literature is troubling because clinically we know that CBTP works best with a team-based approach that includes the client, the relevant supports, and the agency treatment team. So we want to support and encourage clients in identifying support systems that they might be willing to include in their treatment. And here I'll get on my soapbox for just a moment. And I'd like to take a moment here to note that quite often when we're discussing natural supports, we're often discussing one's immediate family. However, it's up to the client to define what people are represented within their family system. So this might include members of one's biological family, a partner, friend, sponsor, neighbor, pastor, so on. Okay. So let's talk about how we discuss integrating supports into therapy with our clients. So first and foremost, as integral to all CBT-based approaches, we want to provide a clear rationale as to why this could be helpful for the client. So how might including a support person help them to achieve their personally identified goals? For example, could this help by having someone to exercise with if their goals are to be more active, by working together to reduce stress in the home if that's one of their treatment goals, by practicing communication skills, helping to notice illness warning signs, and so on. So make this personal and specific to your client and relevant to their specific needs. And once the client is on board with this idea, which is usually the biggest barrier, we want to start to brainstorm and consider which supports might be good candidates for inclusion in therapy. And we can do this collaboratively with clients by asking who their supporters are. For example, starting by asking about those individuals they know well and can trust. Ideally, this is someone that knows about their diagnosis, symptoms, and current treatment plan, or somebody that the client is willing to disclose this information to. Ideally, someone who's open-minded, understanding, and honest, and someone they see regularly or who's relatively available. And as all of you know, it's helpful to note that if a client is living with somebody or has frequent contact with somebody, it's optimal for those individuals to be included in treatment because they're likely to have a significant role in that person's recovery. Okay. So some additional things for you as the clinician to consider and discuss with your client as you plan on integrating supports into your session include your client's cultural and social background, which can influence personal preferences for types of supports that might be included, as well as availability of support. So for example, in some cultures, disclosing mental illness to individuals within or outside of one's cultural background may be challenging, and so it can be helpful to discuss those boundaries with your client. Family dynamics are important to be aware of, so it can be helpful to ask about and be aware of any hierarchies, generational dynamics, gender roles, etc. Trauma, of course, before bringing a support person in, of course, you'll want to consider any trauma history between the individuals coming in and your client. You'll also want to consider any similarities and differences between the supports and the client's understanding of the client's experiences. So where is their agreement and where is their disagreement? And related to this is the support person's mental health history and their experience with services. And really importantly, I think it's important to ask, as the clinician, who is the client? Just kind of check in with yourself about who is the client early on when you're bringing somebody in, and to continue to check in with yourself regarding this, because it can be really challenging to not switch into family therapy mode as a clinician when you're bringing in other support persons. And of course, all of this information that you've considered should be integrated into your clinical formulation, including any interventions that you ultimately deliver. Okay. So I'm also going to spend a moment on client comfort. So many clients might be reluctant to involve supports in sessions, as Sarah will demonstrate today and the rest of the meeting. So when it comes to addressing client discomfort around including supports, the initial work here can be thought of as a mini formulation. So as you normally would, you want to assess relevant thoughts, feelings, and behaviors surrounding the event. And then we can then see what the barriers are and work to best address the needs of the client, whether those needs be around boundary setting. So for example, identifying what is on topic or off topic, generating out of session guidelines. So creating a set of rules or guidelines for when things are discussed or practiced outside of sessions, or even doing some thought challenging with the client if the concerns are linked to symptoms or cognitive distortions. So I'm going to walk you through a brief example of what this quick mini formulation could look like if a portion of the concern is cognitive in nature. All right. Let's say, for example, I'd asked my client Sally about including her husband in sessions. She might have the thought, if he finds out I've started hearing voices, he will leave me. Understandably, then experience some fear and tell me he's overextended at work and can't come in. And let's say that given what I already know about Sally and what I've conceptualized so far, I hypothesize that what's driving this pattern is belief that people will reject her if they find out what's happening to her. Now, in this example, it would probably be helpful to do some cognitive work to challenge some of those underlying beliefs. However, even in this instance, I wouldn't discount discussions with her in terms of what is on and off limits. So perhaps we don't discuss her experiences of voices in those first few sessions with her husband, and use these sessions to model how to establish healthy boundaries with her partner and in other relationships moving forward. Now, I quickly want to touch on two ways that we can incorporate supports into our sessions, and I want to note that this slide was borrowed from Kate Hardy, who did this talk last year. So according to Kate, the first approach here emphasizes as needed involvement of the support person. So here the focus is on bringing in a support person to address a specific topic, such as problem solving, wellness planning, psycho-ed, or setting up a behavioral experiment. And in this approach, you're typically planning for the session ahead of time with the client, bringing in that person, and then debriefing with the client afterwards. The second approach then emphasizes the support person's weekly attendance at that session. So here the focus again is still on the client, but the support person is involved in every session. The clinician here works to incorporate different perspectives and ways in which supports can support the client in their skill building. And broadly speaking, Kate mentioned that this approach might be most helpful for those individuals who are more isolated and where the family system might be their biggest source of support and benefit from having some of that external motivation to have practice skills. All right, so let's talk a little bit more about the different roles that supports can play. So the big one, of course, psychoeducation. Supports are enormously important when it comes to the provision of psychoed, and this can range from providing psychoeducational materials which can be shared with supports, to bringing supports in for psychoeducation focused sessions, to watching video clips together, to having clients teach materials, to supports for home practice. Supports can also be very helpful when it comes to supporting interventions outside of therapy. So helping with tracking symptoms, applying coping strategies, acting as sounding boards for reality checking, encouraging completion of handouts and worksheets. And of course, supports can be great allies in executing behavioral experiments. However, again, one quick note here, I'm sure we can all think of well-meaning support persons who might go overboard with this. So we want to set this up to be collaborative, and this can be why it's very helpful to have that discussion early on about boundaries ahead of time. Okay. The supports can also assist in the event of a crisis, support positive reinforcement and rewards, aid in problem solving, and finally, supports can be tremendous assets when it comes to wellness planning, as are often the people who see and recognize early changes in symptoms. All right, so finally, I would like to spend a few minutes speaking on the topic of support systems and how this is being impacted by COVID-19 and ongoing social distancing guidelines. So we have all been encouraging our clients to stay connected as much as is feasible through telephonic interactions, emails, social media, or video conferencing. And I'm not going to focus on delivering CBTP via telehealth, since we already have a number of great resources on that topic, and even Sarah mentioned a few of those at the beginning of our ECHO clinic today. But I do want to touch on what does staying connected actually look like for our clients right now, and how can we incorporate supports in the era of social distancing. Okay, so let's start with those clients with access to supports. This is an opportunity for us to use home-based sessions to our advantage. So include those supports who may be working from home in sessions if you can. This could be as needed. So for example, I have a client right now who has some memory impairment. I've actually talked about him on a couple of ECHO clinics. And his mom's a teacher, but everyone's home now. And I think she's still working from home. So we bring her in as at the end of every session, or at the end of every 2 sessions, to brief her on the home practice so she can support him in completing them. This can also be done for each session. So I have another client whose partner lives with him and attends every session to provide support, provide his thoughts, and to help complete cognitive restructuring worksheets with him when he starts to feel stuck. Another note here is that when doing this via telehealth, it can be kind of tricky. Since one person can easily walk off screen, and you can also you usually can't see body language. We don't have the benefit of seeing body language. So frequent check-ins or even setting up a game plan for how to manage a disagreement, if it occurs, are helpful. For me personally, I find that telling the client up front with some humor helps this. So we all get to laugh about the awkwardness inherent in some of these telehealth sessions, and they understand why I'm checking in more than usual. Okay, but what about those clients without access to supports or physical access to supports right now? So first, we can consider a telehealth visit. So as we're demonstrating today, we're able to conduct multi-person Zoom calls. However, again, this comes with some unique challenges when individuals aren't physically together. So it can be helpful to set a clear agenda for why you're bringing a person into that session, to gently and assertively draw boundaries regarding what's on and off topic, to proactively agree to a timeout signal, and again, to solicit verbal feedback periodically, since you don't have the benefit of that body language. If a person cannot attend the session, then you can also plan to provide your client with virtual materials that they can share and discuss with supports. These can be simple things like short videos and handouts. And if a client really struggles to identify any support person to include in treatment, this would be a time when I would consider engaging peer supports. Peers can be immensely valuable when it comes to normalizing mental health difficulties, being models for hope and recovery, and practicing skills outside of session. And finally, while not directly related to today's topic, some additional support adjacent activities that we've previously discussed include engaging BA focused on connection and giving back, so things like prayer, meal delivery, sending and receiving letters, signing petitions, and engaging virtually. So I have a client that just joined the Hearing Voices virtual groups, which are happening, I think, every Tuesday at 5:30. And he's really enjoying that, really enjoying engaging with other folks that are having similar experiences as him.